All right, so I was trying to define what a sliding hernia is. So for a sliding hernia, I was trying to give you a very good example of anatomy. Okay, so if this is the body, in the other side is the body, so we know that this side you have the sigmoid colon, of the sigmoid colon on the left, and then on the right you have the ilium. You have the ilium. What else do you have? You have got the cecum this side. So now what happens is that the cecum and the ilium can slide into the inguinal canal, and then the sigmoid colon on the other aspect can also slide into the inguinal canal, and that is known as a sliding hernia. So a sliding hernia is definitely very simple and straightforward, as you can see from the slide, from the PowerPoint. Let me just admit people. Okay. So a sliding hernia is a hernia of a piece of extraperitoneal bowel, the cecum or the terminal ilium on the right and the sigmoid colon on the left, which slides into the inguinal canal, pulling a sac of peritoneum on its surface. This can be very confusing, but what I want you to remember or to understand is that there is just a sliding of the sigmoid colon on the left and the terminal ilium or the cecum on the right. They slide into the inguinal canal. That is known as a sliding hernia. So Dr. Success asked me about this. Very, very important. So just make sure that you understand it properly and see how you can explain it if you are to encounter it in an exam. So now surgical anatomy, very, very important. So surgical anatomy, very, very important. These are the things that we need to know. If we check through the papers, we are going to find most of the things, especially this slide. So surgical anatomy, what are we supposed to know about the inguinal hernia, the famous inguinal hernia and the famous femoral hernia? What are we supposed to know about this? So for the inguinal hernia, you have to remember there is a mnemonic. I don't know if it's a mnemonic or an acronym, but it should be a mnemonic. Let me just circle it. It's here. So this is the mnemonic here. I am. And then you have a FBL on the other aspect. This was given by the senior registrar, Dr. Success. So AHEM is the mnemonic for the inguinal hernia. So the inguinal hernia is above. So I for what? Let me just write something. So I am. That is for inguinal hernia, which means or implies that inguinal hernias is above the inguinal ligament, and medial to the pubic tubercle. So this we have to remember, whether we like it or not. We have to remember. So I'm saying that the inguinal hernias, regardless of a type. So for as long as you're talking about the inguinal hernias, these are above the inguinal ligament and medial to the pubic tubercle. That's the mnemonic IM. Femoral hernias, these are hernias that are below, and so they are below the inguinal ligament and they are lateral to the pubic tubercle. This we have to remember. So these two mnemonics, they're just trying to help us to remember these things very well. That is why they made them, because they know that they realize that it's not easy for us to just remember that the inguinal hernia is above this. It's above and immediate to the inguinal ligament. The other thing is that depending on the type of the inguinal hernia, you have got two. Remember, you have got two types of inguinal hernias. You have got direct and indirect. So the indirect one, the indirect inguinal hernia, it passes through the Hasselbalch's triangle, which we are going to talk about very soon. The Hasselbalch's triangle. While the indirect, it goes through the deep inguinal ring up to the scrotum. That one is through the inguinal canal. That one is through the inguinal canal. While the femoral hernia is through the femoral canal. So we have to remember that. Next. So the other thing, or the other 2 points that are very important, these ones, they are also important. So we have these 2 things, or these 2 terms that confuse us a lot. You have what is known as the mid-inguinal point and the midpoint of the actual inguinal ligament. So I'm going to draw something that will make people remember. So, for example, if this is the pelvis, remember I'm just trying to estimate here. If that is the pelvis or the pelvic bone, you have the axis here, anterior superior iliac spine is going to be here. And then you have I don't know if it's the ischium. You are going to have the pubic tubercle here. I'm going to put the pubic tubercle here as a dark dot. And then I'll say my pubic symphysis is somewhere here. I'm just estimating. So a line or a point midway, a point halfway between the anterior superior iliac spine axis. This is the pubic symphysis, pubic symphysis. Pubic symphysis. So now the line midway, the line halfway between the two, the line, the point, you've got this point that is connecting the anterior superior iliac spine up to the pubic symphysis. So now we are saying that the point halfway between these two, is known as the midpoint of the inguinal ligament. So now that point is a landmark for the femoral artery. So whenever you are palpating or you want to feel for the pulse, the pulse for the femoral artery, you just estimate the point halfway between the anterior superior iliac spine and the pubic symphysis. That is known as the midpoint or the mid-inguinal point. And then you have got the midpoint of the actual inguinal ligament. These 2 terms confuse us a lot. So the second one is between the axis and the pubic tubercle here. And it's the landmark for the deep inguinal ring. The deep inguinal ring. Deep inguinal ring. These 2, we don't have to forget them, please, guys. They are very important, especially the midpoint of the actual inguinal ligament, because it's a marker for the deep inguinal ring. That's why you put your thumb. You put your thumb there, you close that canal. When you close that canal, you ask the patient to cough. When they cough, what happens is that if the hernia is indirect inguinal hernia, it doesn't pass through the canal, and therefore you cannot see the bulging. So that will help you diagnose whether it's direct or indirect inguinal hernia. And that test is known as what? Deep or rather internal ring occlusion test. That is what you do during examination. In short, know these 2 points very, very well. I don't know if it's clear. Next, so what's so important about the direct inguinal hernia? What are we supposed to know? So for the direct, I already said that these are the ones that protrude through the Hasselbalch's triangle. The other thing is that These are medial to the inferior epigastric vessels. The indirect are lateral to the inferior epigastric vessels. How and why? That is very important as well. So we have to know the triangle. The triangle. So if this is the abdomen, this is the abdomen, you are going to have these two triangles. This triangle A and the other triangle A. So triangle number 1 and triangle number 2. Triangle number 2 is on the left side. Triangle number 1 is on the right side. So this triangle has got boundaries that we have to know as medical students. This is going to be called the medial border of this triangle. This is going to be called the lateral border. And then the base of the triangle. And then you have got the apex of the triangle. So the medial aspect is formed by the lateral. Remember, you're going to have the rectus abdominis muscle here. You're going to have that rectus abdominis muscle there. You're going to have this line here, which is the arcuate line. Is it the arcuate line or the linea alba? The linea alba, sorry. So this is the linea alba. So now I'm saying that this triangle is going to have the medial aspect. So the medial aspect of this triangle is formed by the lateral border of the muscle, which is the rectus abdominis muscle. Simple. The lateral border of this triangle is formed by the inferior epigastric vessels, while the base is formed by the inguinal ligament. So this point or this triangle is known as the Haselbach's triangle or inguinal triangle. This triangle is the weakest point or is the potential weakness for the direct inguinal hernia. So herniation, direct inguinal hernia can happen through E. That is why this type of hernia, the direct inguinal hernia, is inferior to the, not inferior, is medial to the epigastric vessels, which form the same lateral aspect of the triangle. I hope that is clear because we have to know this as well. Okay. Okay. So indirect inguinal hernia, these hernias we are saying that they are lateral to the inferior epigastric vessels. And this can also happen congenitally, like I said, when there is when the processus vaginalis does not what? I've forgotten the medical term. If it persists, it's supposed to go to obliterate. Now, if it fails to obliterate, it remains patent. That is going to be congenital. And these are the ones that have a high risk of strangulation than the direct inguinal hernia. So again, we have to know the inguinal canal boundaries. These we have to know. Next. So this slide is just showing you the differences between the direct and the indirect. So the direct, it doesn't go into the scrotum. Okay, that's the other slide that is summarizing everything here. So the indirect inguinal hernia is passed through the inguinal canal. Well, this one is through the Haselbach's triangle. The indirect inguinal hernia can descend into the scrotum. The direct cannot. The indirect is lateral to the inferior epigastric vessels. The other one is medial. The other thing is that the direct inguinal hernia is common in elderly. So remember, I told you that when as men age or when people age, what happens is that their muscles become weak, and that predisposes them to herniation. So common in old people. This one is common in children and young adults, the indirect. Why in children it can be due to the patent processus vaginalis. The other thing is that these hernias are common on the right side. The hernias are common on the right side. Why? Because Dr. Success said that during the descending of those hernias, the right testicles, or rather, the right testicles takes time, or it's slow in descending. So it is the one that is highly predisposed to herniation. What that? The other thing is, okay, I'm going to talk about it very soon. So what are differentials? What are differentials is for swelling that you see in the testicles, whatever, or differentials for hernias? So you have got lymphoma, you have testicular tumors, you have got varicocele, you've got epididymitis, which is the inflammation of the epididymis. You can have testicular torsion, you can have hydrocele, fluid accumulation in the testicles. You can have ectopic or an descended testicle. A testicle has never descended. It is just in the abdomen. That can be differential as well. You can have hematoma, ascites. You can have a femoral artery aneurysm. So now remember, if we've talked about femoral hernia. So if there's that bulging in the femoral artery, which is in the femoral canal there, that can be also a differential as well. So how do you take history and the examination of inguinal hernias? So mostly the patient will present with pain, but not always. The pain is more common and tender when there is strangulation. The lump gets smaller when lying down, and the patient may have noticed that the swelling can be pushed back into the abdomen. The patient, or rather the presentation, the age is not the factor, meaning that the hernia can appear at any age. But remember, with the different types of hernias, this rule is not always true. Occupation, if you ask them what do you work, they'll tell you that they have been doing heavy work. They've been lifting something that is heavy, and that is going to help you make a diagnosis. So heavy work occupation, they are most likely to have hernias because of an increase in intra-abdominal pressure. Local symptoms, they have discomfort, pain. Now patients, or they complain of a dragging or aching sensation in their groin, which gets worse as the day goes on. So abdominal symptoms, if the pain becomes very painful and tender, it means that the hernia has strangulated or strangulation has occurred. So remember, the hernias, they can cause or rather they cause intestinal obstruction. So now if the pain is colic, it comes and goes. That is known as colic. So that is likely to tell you that the loop in the hernia has been obstructed. You ask them, has your bio recent reaction changed? For example, have you been going to the toilet? Why? Because hernias cause intestinal obstruction. Ask also about other diseases which may cause increased intra-abdominal pressure, such as chronic bronchitis, because the patient is going to be coughing, and that is also a predisposing factor that increases intra-abdominal pressure. So remember, when coughing, the diaphragm contracts, it depresses, and that it pushes, or it puts pressure on the intra-abdominal vessel, and hence increasing the intra-abdominal pressure. Have they been having any difficulty in nutrition or urinating? Because remember, nutrition also increases what? Intra-abdominal pressure. How to examine the patient with a hernia? So you talk about the size of that hernia. You talk about the color surrounding the hernia. So if the color is reddened, it's red, it means that the hernia is strangulated. Temperature, supposed to be same as the surrounding. Is it tender? If it's tender, remember there's a chance that the hernia is strangulated. The shape, what's the shape of that hernia? The indirect hernia is somewhat sausage shaped. The direct hernia is usually round. The surface is always is usually smooth. The composition and the cough impulse. A hernia will nearly always become larger and more tense in all directions during coughing, which is referred to as an expansor cough impulse. That is why when you occlude that thumb on the deep inguinal ring and you ask the patient to cough, the bulging is supposed to come out if it's direct. If it's indirect, it's not supposed to come out because you've occluded that rumen or the canal. So the internal ring occlusion test, this one is very important. So you tell the patient to lie in supine position, then you reduce the hernia. After reducing the hernia, you occlude the internal ring using your thumb. How do you occlude? How do you ascertain or tell that this is the internal ring that I'm occluding? So you apply the mid-inguinal point of the actual inguinal ligament, which is the point halfway between the RCC and the pubic tubercle. You just go there, 1.25 centimeters above there, you occlude. But after occluding, you ask the patient to cough. So when they cough, since you've occluded the deep inguinal ring, where the indirect inguinal hernia passes through. So the indirect inguinal hernia, the sac cannot pass there. It cannot pass there because you've occluded the internal inguinal ring. Therefore, you cannot see it. So for direct, the hernia is going to appear medial to the thumb. For indirect inguinal hernia, there will be no swelling. You cannot see it. And then the Zeimann's test, you're going to read it this one. So how do you manage him? So management, you have got pre-operative before you do the operation, and then you've got surgical options such as eniotomy, which involves the cutting of the sac in children, specifically in children. That's eniotomy. Eniography. So eniography is strengthening of the posterior of the inguinal canal, so that when you strengthen it, when it becomes very powerful, when it has that impamvu, it means that at least you are going to it's more like you're doing a prophylaxis. You are preventing the hernia to happen later in future. And then you can do the henioplasty, where which involves the putting of a mesh. I don't know how they put it. I just read it like that. So what can lead to recurrence or the hernia to happen again? Those are the factors that are there: malnutrition, immunosuppression, diabetes, steroid use like diclofenac, smoking, technical factors such as mesh size, tissue factors, wound infection, ischemia, and the likes. What are the complications of hernias? So you have got early complications. So remember this year, whenever they ask you about complications, you have to tell them which ones are early, which ones are late, which ones are intermediate. For early, you are going to have pain, bleeding, urinary retention, anesthesia related. This can be due to anesthesia related, the bleeding, the urinary retention. Intermediate, you can have seroma, which is just accumulation of maybe neutrophils or dying tissue in the third space. How can I explain this? Forgotten. Wound infection under intermediate. Late, you can have chronic pain, testicular atrophy, and recurrence. So that's the end of our today's discussion. And this is the last PowerPoint, last slide, which is saying that or which has a quote from Sir Astry that no disease of the human body belonging to the province of the surgeon requires in its treatment a better combination of accurate anatomical knowledge with surgical skills and hernia in its all varieties. This is telling us that we need to understand the anatomy before we need to understand the anatomy and the surgical skill for us to manage hernias properly. So we need to know where the femoral canal is. We need to know where the inguinal triangle is. We need to know where the Hasselbalch triangle is. We need to know the abdominal wall layers and everything for us to understand what hernias are. So that was our tonight's discussion. Thank you so very much for attention. If you have got questions, you can ask, please. Thank you so very much. Thank you, Marisopo. Thank you. Any questions, additions?